Welcome to today's Explainer. I'm absolutely thrilled you're joining me for what's going to be a really high-yield clinical lecture on ocular pharmacology. As clinicians, we're constantly having to manipulate the eye's internal muscles, right? Whether that's dilating the pupil to get a crystal clear view of the fundus or completely paralyzing accommodation so we can nail a perfectly accurate refraction. But how exactly do we hack the nervous system to achieve this? And what are the hidden dangers lurking in those little dropper bottles? Well, let's dive into this fascinating pharmacological tug-of-war.
All right, here's our game plan for today. We're going to cover autonomic physiology, parasympatholytics, sympathomimetics, and we'll wrap up with the ultimate clinical red flag, glaucoma. Let's get right to it.
Okay, part 1, autonomic physiology and dual control. So before we even touch the eye drops, why do we mess with ocular physiology in the first place? Well, clinically, we need to dilate the pupil to get a really good, comprehensive evaluation of the fundus. And we paralyze accommodation to accurately measure refractive errors, like myopia and hyperopia, especially in our pediatric patients. Now, looking at this cross-section here, our main targets are the iris, which controls the pupil size, and the ciliary body, which changes the shape of the lens. These structures are basically the battleground for the two main branches of the autonomic nervous system.
It's actually kind of beautiful how perfectly opposed these two systems are. Think of it like a push and pull. The parasympathetic nervous system, the PNS, uses M3 receptors to contract the circular sphincter muscle of the iris. That causes miosis, or constriction. It pulls the pupil shut. But on the flip side, we have the sympathetic nervous system, the SNS. It uses alpha-1 receptors to contract the radial muscles. And when those radial muscles flex, they physically pull the pupil wide open. We call that active mydriasis.
But hey, the pupil is only half the story here. We absolutely have to talk about the ciliary muscle. When the PNS fires, that ciliary muscle contracts, and paradoxically, that actually loosens the suspensory ligaments, which lets the lens thicken up for near vision. That's accommodation. So cycloplegia is simply the paralysis of that ciliary muscle. By blocking the PNS, the muscle relaxes, the lens flattens right out, and boom, the eye is locked into far vision focus.
Moving right along to part 2, the parasympatholytics, also known as cholinergic antagonists.
Now that we've got the physiology down, let's look at how we actually chemically hack these pathways. The mechanism of action here is super straightforward. These drugs are blockers. Specifically, they block the muscarinic M3 receptors. By completely cutting off that PNS signal, the circular muscle of the iris can't contract. So what happens? The sphincter just relaxes, and the pupil naturally falls open. That's what we call passive mydriasis. And because it's also preventing the ciliary muscle from contracting, we get full-blown cycloplegia right along with it.
And that brings us to a massive clinical pearl. When we block those M3 receptors to get cycloplegia, we are literally taking away our patient's ability to focus on anything up close. In the literature, this is called iatrogenic presbyopia. Basically, it's a temporary, drug-induced loss of near vision. You absolutely must warn your patients about this before they leave the chair, or they're going to be pretty panicked when they can't even read a text message on the way home.
So how do we choose which drug to use? It all comes down to the duration of action. Look at atropine on this table. Its effects stick around for a massive 7 to 10 days. That's amazing for treating severe inflammation or a lazy eye, but it's an absolute nightmare for a routine exam. For a pediatric refraction, cyclopentolate is your best friend, giving you solid cycloplegia for about 24 hours. And for a standard adult fundus exam where you just need to open the pupil, tropicamide is the gold standard. It does the job and wears off in a very manageable 6 hours. Now, you might be wondering, why on earth would we want a drop like atropine to last for over a week? Well, it comes down to what we call the adhesion rule. If a patient comes in with severe anterior chamber inflammation, like uveitis or iritis, the eye fills with these sticky inflammatory proteins. And if we do nothing, the iris can permanently glue itself to the lens. By using a heavy-duty, long-acting parasympatholytic, we dilate that pupil and physically yank the iris away from the lens, breaking those adhesions or stopping them before they even start.
All right, part 3, sympathomimetics, or adrenergic agonists. If the drugs we just talked about achieve dilation by being passive, by blocking constriction, these drugs take a much more direct approach. Their mechanism of action relies on actively hitting the gas pedal. They stimulate the alpha-1 receptors located on those radial iris muscles. When stimulated, those muscles contract and forcefully pull the pupil open. Phenylephrine is the classic example here. We use it all the time in combo drops for fundus exams, and even as an ocular decongestant since it shrinks conjunctival blood vessels. But a quick warning, Because it's an adrenergic agonist, if it gets absorbed systemically, you can see spikes in blood pressure and even arrhythmias. So always proceed with caution.
So here is the absolutely crucial technical distinction between the two classes. Sympathomimetics cause active mydriasis, but with zero cycloplegia. Why? Because the sympathetic nervous system doesn't really control the ciliary muscles near focus in the same way. So if you use a drug like phenylephrine, you blow the pupil wide open, but the patient's near vision is totally intact. Parasympatholytics, on the other hand, give you passive mydriasis and completely wipe out that near vision.
Which brings us to part 4, glaucoma and the ultimate red flag.
We manipulate the iris every single day, right? It's routine. But in the wrong anatomical environment, it can be an absolute disaster. Think about this for a second. What mechanically happens inside the eye when a chemically dilated iris gets forced to bunch up in a very tight, crowded space? Well, it causes angle crowding, and that leads to acute angle closure glaucoma. When you dilate the pupil, that iris tissue folds up like an accordion. If a patient already has narrow drainage angles, which, by the way, is super common in your hyperopic, far-sighted patients, that bunched up iris physically clogs the trabecular meshwork. The eye keeps making fluid, but it has nowhere to drain. The intraocular pressure spikes dramatically. This is a true medical emergency. We're talking sudden, agonizing eye pain, a rock-hard red eye, halos around lights, and even systemic nausea. Because of this catastrophic risk, atropine and basically all mydriatics are strictly contraindicated in narrow-angle glaucoma. So here's your golden rule for clinical safety. Write this down. Always, always check the patient's intraocular pressure and assess their anterior chamber depth before you put those drops in. If you skip this step, you could trigger an acute attack and cause permanent, irreversible optic nerve damage. To tie all this pharmacology together, we can neatly sort our commonly used mydriatics into two main buckets. We've got our anticholinergics, your atropine, cyclopentolate, and tropicamide, which passively dilate the pupil and paralyze accommodation. And then we've got our adrenergics, like phenylephrine, which actively force the pupil open without freezing those focusing muscles. Two totally distinct chemical pathways, each with their own specific clinical jobs. I want to leave you with one final provocative thought today. We've been talking entirely about topical eye drops. But what if a patient rolls into the ER with sudden, severe eye pain, a mid-dilated pupil, and a massive IOP spike? Could their daily pills be to blame? Absolutely. The literature warns us that systemic medications, like anticholinergics for an overactive bladder, or even drugs like topiramate, can absolutely induce iatrogenic presbyopia and trigger acute angle closure glaucoma right from the inside out. It's like a giant puzzle. You've got to look at the whole patient and always respect the sheer power of autonomic pharmacology. Thanks for joining me for this explainer. I really hope this makes your next clinical shift a little sharper.